Hey besties, welcome to Get Fit in Your 40s, where we get real about our own journeys and how we have helped thousands of women figure out why what worked in their 20s isn't cutting it anymore.
We are your hosts, Duki and Kausar, your fitness BFFs, here to help you navigate losing weight and getting healthier in your 40s and beyond. Let's get into it. Welcome to another episode of Get Fit in Your 40s. I'm your host, Duki, and usually I'm here with my best friend and business partner, but today is a little bit different. We have a very special guest. She's going to be diving into how do I know if I'm in perimenopause? Do I need any treatment? What is hormonal replacement therapy, HRT? Do I need it? Where to go? All of those questions that we know that you're basically asking yourself. So now let me properly introduce Dr. Nicole Tully. She's a board-certified physician specializing in women's health with nearly 2 decades of experience. Dr. Tully earned her Bachelor of Arts in Biology and French Studies from Brown University, followed by a Doctor of Medicine, MD, from Rogers University. She completed her family medicine residency at the same institution and is diplomate of the American Board of Family Medicine. Additionally, she's a certified menopause practitioner by the Menopause Society. Throughout her career, Dr. Tully has been recognized for her dedication to patient care, receiving the Gold Humanism in Medicine Award in 2000. She was also recognized among the top docs in 2017. Her greatest passion lies in supporting women through transformational life stages, including pregnancy, the postpartum period, perimenopause, and the menopausal transition. Welcome, Dr. Tully.
Thank you so much.
What a pleasure to have you here as our first guest in the podcast.
It is my absolute pleasure. This is one of my passion projects now that I've been in practice for so long. I've spent the last 20 years helping women through, as you read beautifully, thank you, the transition of life. And as we age and we go through getting our period as adolescents, and some of us considering families and all of what happens after postpartum period, but really finding ourselves in a time of our life that is not so celebrated, but very confusing with 1,000 different symptoms that can be related to perimenopause. And we don't know. For some people, it happens very young, and for some people it doesn't happen at all. But how to transition and find our way and find our answers on why we're feeling this way is really what I've spent the last 3+ years doing and learning.
Yeah,
so
true.
It's just great to be here.
Oh, thank you so much for coming. I always tell our followers and our clients that we are part of history now, because for years we were very confused and overwhelmed. So thank God we have doctors like you taking care of this transition in life, because it's, as I say, very overwhelming. I know that you have your private practice, so how did this happen?
Yes, I made this big transition for myself several years ago when I realized, as I was going through these changes, that something wasn't right. When I started medical school, it was when the World Health Organization came out and stopped a major study looking at hormone replacement and said, everyone stop, because you're going to have cancer, you're going to die of heart disease, and everyone's going to get breast cancer, right? It was one of those where we couldn't help patients, and all we told them was, you can't take estrogen, stop everything you're doing, and just grin and bear it, and we'll try to help with some symptoms along the way. But what I realized is that there's so many concerns that women had, I couldn't fit it in. I couldn't fit it into my day. I was seeing 100 patients a week or more sometimes, and a lot of them just feeling terrible. Some of them from menopause and some of them from not, but really teasing it out and really helping address all those symptoms, I realized I needed more time and I needed to do more for these patients. So I left my traditional practice of medicine and I started something called a concierge medical practice, where I spend an hour with every one of my patients. They have my cell phone, they call me when they need me, and I do everything. I trained in family medicine, so I don't only do the gynecology, I do the HAPs and the pills and the bleeding, if there are concerns and issues that way. But I also take care of the hypertension, I take care of the dyslipidemia, I take care of the weight gain, I take care of the hair loss and the mood swings and the palpitations and the sleeplessness that comes with menopause. And I train to do all of that. So now I can for all my patients because I have an hour of time. And then if we do start a plan, a medicine, an idea of let's track this for 2 weeks. They call me, they text me, they send me all their results. So it's just been amazing to be able to do this with my patients. With cost of medicine and just being able to survive. I just had some friends text me that they practice in a state north of us. They were in this wonderful practice and it was going just fine. And all of a sudden the next day they declared bankruptcy and closed. And they were seeing the 150 patients a week per doctor. And they were seeing, but all of a sudden because of healthcare costs and everything not being met. So it's become harder and harder for doctors to provide care for patients unless they see a ridiculous amount of them. And with COVID, a lot of primary care doctors retired or got sick. And so there's a big shortage. And so I realized, again, instead of me having a 4-month wait list to see me, I'm just going to be available for my patients. I'm going to have a few of them, and I'm going to take really good care of them. And so this is why I am so lucky, and I hope my patients feel that too.
You are. What an accomplishment that you can do what you love and helping them deeply than the system. I bet that they are happier with you too.
Almost every day. I think my patients have told me how happy they are and thankful that I was able to stay late and come at 7 o'clock to see them after I had gone home and they were available after work. So it's been wonderful for my patients, especially with menopause symptoms like the sleeplessness, the weight gain with not feeling well.
Totally. So I think that is a great way to start this conversation that is going to be a little bit heavy but interesting. So grab your coffee, your tea, your notebook, and let's take notes, because what we're about to talk here is gold. Many of our clients and followers have many questions, so I have a bunch of questions here. Let's just start by, how do we know that we're in perimenopause? In my personal experience, we have some symptoms. Some women have no symptoms. So how do we know that we are in perimenopause?
That's a great question. I think for every one person, it's completely different. Sometimes it can be a small shift in your period. So we know in medicine that there are traditional norms that we expect some women to have. The majority of the time, it's that funny period. When you had perfect periods, they came every 20, 30 days, and now they're 27, and they're shorter or longer or lighter. A transition, and it's how we call these periods through menopause, the menopause transition. They're different stages and based on what symptoms people are having. So the earliest sign is usually a funny period when it wasn't happening before. Sometimes not. Sometimes it can be from something else, like diabetes or weight or thyroid. So
some of my friends were a little bit scared that they were getting pregnant.
Probably 40% of all pregnancies in their 40s are unintended pregnancies because people think, oh, it's probably menopause. But no, you can very much still get pregnant.
Be very careful, bestie.
Yes.
It can happen.
It can happen. So it's super important to talk to your doctor to make sure that you are being protected, and no matter what kind of decisions you're making or what symptoms you're having. But usually, again, symptoms are a funny period. Hot flashes, night sweats. Some people tell me I've been having night sweats every time I've had my period since I was like 20. And some people do, but it change, right? Weight is a big one, and you've seen that too, right? So after menopause, 1 pound to 1.5 pounds on average per year happens after menopause. And you tell everyone what to do about that all the time, so I won't go there. But those are a lot of them. Sometimes people will have unusual symptoms like heart racing out of the blue. We'll have vertigo symptoms where all of a sudden they start having recurrent episodes of these. They can't stand. They feel like they're going to fall over, or like extreme dizziness. And a lot of things coincide with higher risks, like higher risks of heart disease, which happens in this menopause transition, right? Cholesterol goes up, blood pressure goes up. So all these medical things happen around the same time menopause is happening that people don't even recognize. Those are the typical symptoms. How to quantify it? People come in all the time. Dr. Tully, can you please have my blood work? I think I'm menopausal. And it can give us some insight, but those levels change month to month. They change day to day. And I've had people who haven't had their period at all and have perfect blood work, like that of a 16-year-old at the age of 45. And then I've had people who haven't gotten their period in a year and had no idea that they were menopausal because they had no symptoms.
Okay.
There are criteria if you're very young in your early 40s and miss a period for more than 4 months. There is a blood test that can be done, and 2 readings a month apart over a certain level will suspect that you're early, very early in menopause, but usually not having a period for 1 year is usually that line in the sand of menopause.
That we are in perimenopause.
Yes. So I always tell my patients when they start to get a little funny period, write it all down because we don't know when the last one's going to be. And that's how we usually go. But the blood work is a little bit less reliable.
Yeah, let's talk about the blood work.
Yeah.
Because I think that is the main thing that I did. And my clients and followers are like, where should I go? So I'm having these crazy symptoms. For example, in my case, I have the vertigo, which is very unusual. And then I thought when I was having it, I was like, oh, I have a brain tumor. So that is like what is happening to me? And then I went to the doctor and then they sent me to the ENT and then it passed. I realized that the more stressed I was, that was a trigger for my vertigo. But I put it like in the drawer. I forgot about it. And then when I started studying, I'm like, this was a symptom that I didn't know. It was due to perimenopause. The heart palpitations, oh my God, I have to go to the cardiologist. Like it's all these different symptoms and you just have to start going to different specialists for this. So where do? We go to the PCP, we go to the gynecologist, the endocrinologist. We feel like that. What is the next step?
That's a very good question. There are some primary care doctors. I think it's important, depends on where you are and who you're seeing. Like I do all of it, right? So I'm the PCP, I'm the GYN, I do the endocrine. I am the all of it, but there are some PCPs when you walk in and you say, I think I'm in menopause, they're gonna freak out and run out the door because they want nothing to do with menopause. They didn't teach it. They didn't teach it in med school, they didn't teach it in residency, they didn't teach it for the last 20 years. So anyone who's just come out of medical school may have had a little inkling, but they're very young and have no way to really know or live it. So I think that it's really hard to find menopause providers at this point. You really do need to find someone who is a menopause provider. So the Menopause Society has a list on their website of certified providers, ideally doctors, because you're coming in with a lot of symptoms. You're coming up with a lot of very real symptoms. So there are therapists, there's pelvic floor people, there's chiropractors, and people can be certified in menopause, but you really want to find a doctor ideally who can help you through and guide you to get the right evaluations.
Yeah, exactly, because that's what happens. We were talking about the blood work, right? So I go to the doctor and I know that for most of us that has been the experience, and they tell you're too young, or they tell you can take the birth control pill, or this is gonna pass, or this is just part of what it is, or they dismiss, just go to the psychologist, because anxiety and symptoms of depression is another symptom that I have heard and I have lived. So it's like the psychiatrist, therapy, all of that. So you ask for a blood work. Do we need that in order to get treatment? Do we ask for it, or really it doesn't matter? Because I know that you just talk about that if I miss a period for 4 months, definitely you have to go and check because menopause might be approaching. But then if I go to the blood work, should I ask for a blood work then, or?
I think with the missed period, when you had perfect periods, I think it's very important to seek medical care. One, blood work is very important because we're also ruling out other things. So we're ruling out pregnancy, we're ruling out thyroid disease, we're ruling out something called elevated prolactin levels, which can be from a tiny tumor in your brain that can cause periods to stop. And so any patient who comes in and they tell me that they haven't had their period and these symptoms may or may not be happening, I always run that panel regardless. And I will run the hormone levels for menopause to give us an idea, but tell people it really has little impact on the advice I'm going to give them. It may give us insight, but that one reading doesn't count for anything. We need follow-up information and follow-up blood work. So I think blood work is important. And again, who does it? A primary care may or may not be comfortable with it and should be comfortable with it. Endocrine will definitely be comfortable with it. But again, an endocrinologist ideally who's very comfortable with menopause as well. And usually their staff will be good enough when you call to ask questions and say, does Dr. So-and-so endocrinologist see a lot of menopausal patients and treat them for menopause? And if so, then that would be a really great person to see.
Okay.
Yeah.
So what if I have irregular periods or maybe regular periods, I'm having the symptoms, and then you do the blood work, doctors that are not menopause informed, told me the blood work is okay. What do I do?
So the thing is, you're having very real symptoms. And if it coincides with the months that you have a normal period, you're totally fine. And the months that you skip your period, you're miserable, hot flashy, haven't slept, moody, all of those symptoms or more, or the palpitations, night sweats, you still need treatment. You can still get treatment even though you're still getting normal periods. The problem is with menopause, symptoms can start 10 years before. And that's what we call this perimenopause. So women can be in menopause for 10 years, sometimes more. There's about 15% of women that have menopause symptoms until they die. We have to address this because it is people's livelihood. If they don't sleep, if their mood is not well, all of it has major impacts. And some of the things, right? Joint pain, we didn't talk about joint pain. So joint pain is a very real sign of menopause or symptom of menopause that people don't think about. It's their hip, their knees, their hands, like all of it. And
they tell there is arthritis. That is the diagnosis that I have heard from my clients.
A lot of times it may be. And so imaging, physical therapy, regular exercise. But I can tell you, I've treated so many women with estrogen who are having all these other menopause symptoms. And they're like, my hands don't hurt. I wake up and I'm not in pain. My knees, I can run again. And it's pretty dramatic. It's very dramatic.
The Women's Health Initiative research that was made in 2012 is very controversial, right? News was, it's going to give you cancer. When they did the research, a lot of negative things came out of that study. So can you tell us a little bit more why we shouldn't be scared?
Absolutely. So I think 2002. Even
2002.
longer, because it was 20 years of this void of information. It was a long time ago, and it took a good, again, almost 20 years before we had more data and really relooked at that data and realized that women, the minute they had a menopause symptom back in 1990, women were put on hormone replacement and they took it until they died because they were happy, they slept well, they didn't have hot flashes, their bones were nice and strong, and it was great. And so they enrolled all these women in the study and followed them for 40 years of use. The problem is sometimes they would start when they had first menopause symptoms. Some of them started in their 60s when they already had heart disease, when they already had cancers that were not detected yet. And all of these people and all that information came into this study. And what did we find? That women, especially if they were older, were having higher rates of breast cancer and heart disease and strokes or blood clots from using these hormones. When we looked at the young women who were usually less than 50, especially if they only use estrogen, actually they had lower rates of breast cancer, they had lower rates of heart disease. The slight risk of blood clots still happened because estrogen happens at any point. Even when you're 20 and you take estrogen, there's a small risk, but that risk is low. The benefits that come from it, only we can decide whether we want to or not. So that still probably stands regardless of age. But the idea is that it was more helpful than harmful. Now, a lot of the studies 20 years later, and even looking back at that data, we see that if you are young and you're healthy and you take it for a short period of time, right around the time of menopause, ideally less than 5 years, but less than 10 years and less than 60, those rates of heart disease, strokes, and breast cancer are very low. And again, if you're in pain, if you can't sleep, if your mood is terrible, if you can't have a normal shirt on without sweating through it, then for people just feeling well, it makes sense to try to be on estrogen. If that's the reason why you're taking it, some people will use it indefinitely without concern. There are some longevity studies looking at women who are taking it more than those 10 years after 60. And those studies are looking very positive now. Again, really healthy women with low risks of strokes and heart attacks and cancers. All those women are, so far, the data looks good, but it's not out yet. So there's hope that if the estrogen is helping us feel well, then that will be good. But the idea is it doesn't always have to be estrogen, and there's some women that can't take estrogen. And often with estrogen, there's a lot of other different medications that are part of that hormone replacement therapy that is definitely worth talking about as well.
Yeah. Okay, so that is the other question. What is the treatment? What is hormonal replacement therapy? That comes in pills, creams? Just tell us all about it.
Sure. Yes. Those two and a couple other things. Hormone replacement therapy, it really depends what your health status is as far as two things. One is, do you have a uterus or do you not have a uterus? And when we're talking about hormone replacement, we also think of how old you are and whether or not you're having periods still. If you're having periods, it's thought that you may still get pregnant. And hormone replacement, those levels are not high enough to suppress you from ovulating. And if you're ovulating, then there's a chance you can get pregnant. For those people, we often talk about birth control. A low-dose birth control you can take. There are studies looking at even taking it to 55 now and still having it be safe. It helps all of your symptoms of menopause. And then at 55 or sometimes 52, really talking to your patients and patients talking to your doctor, you can figure out when you want to try coming off and seeing if you have symptoms. Some people, when they come off, there's a little transition period, but may not have symptoms, and you avoided all those crazy extreme hot flashes, night sweats that happen for years and years. You might get them for a month or two, but then all of a sudden you feel fine and life goes on. So that's for the young perimenopause that are still having regular periods.
We can take a
birth control pills.
Birth control pills that is going to help you with
Exactly.
perimenopause symptoms.
Exactly. Now, those people can also benefit from an IUD with progesterone. That protects your uterus, but also if they're having the hot flashes and night sweats, we can then give estrogen separately. So if women are done with having their periods, it depends if they have a uterus or not. If they don't have their uterus for surgical reasons, then they can just use estrogen alone. And if they haven't had surgery, then they need progesterone, because if you use estrogen alone without the progesterone, then there's a higher risk of endometrial cancer. You need, most women, if they haven't had surgery, need both estrogen and progesterone. And that comes in different forms. The estrogen comes in the form of pills, comes in the form of patches, it comes in the form of gels that are applied topically. All right, the pills you swallow. The gels are applied topically, the patches are applied topically. The gel's usually on the upper arm, the patches usually lower abdomen or lower back, and then you switch them out. Sometimes the patches come combination.
Okay.
There are original estrogens. That's usually not enough to help all the systemic symptoms of the hot flashes and night sweats. That's usually for symptoms of vaginal dryness, pain with sex, decreased libido, climb and orgasmus. So that's different kind of estrogen that we use vaginally. But yes, there's also intravaginal gels and intravaginal tablets. There's a lot of stuff in intravaginal suppositories.
And it's not normal to have low libido, because I think we don't talk enough about that, because people feel embarrassed maybe. So that is another symptom of perimenopause and menopause, and you shouldn't be living that way.
No. In fact, with every menopause patient I talk to, I ask everyone about pain, dryness, interest, desire, orgasms, and what sex life is like. Just because you're not having sex infrequently doesn't mean it's terrible and you have a terrible sex life. It really depends on what you and your partner, or you or yourself, really want to get out of sexual life. So I think it's really important to have someone you can talk to about that, and having a physician that's open to it. I asked my cute little 80-year-olds, and they're like, what? I haven't had sex in forever. Or I've loved when I've had my 80-year-olds that have had wonderful sex lives. And it's just wonderful to know that it's all still possible, but it's really asking for help and being open to suggestions. And so I really talk about it with everyone. It's totally embarrassing for some people, but I'm like, if you don't feel comfortable, we don't have to talk about it. But if there's a question, I really want to be here to answer for.
Exactly. No, super interesting, and you needed to hear that. I know that.
Yes. No, lots of questions about sex.
So what about the pellet?
Oh, okay. Yeah. So the pellets, the Menopause Society, and pretty much every literature that comes out suggests that the pellets are not advised. The problem is that there are high doses of hormones in them. You don't know how you're going to react. And they're in there indefinitely. They're literally, they put the pellets in and they stay there. So you have a foreign body in your body, underneath your skin, until the end. It's with you. You can't reverse the symptoms. I've had patients come in with severe symptoms: nausea, headaches, chest pain, irregular bleeding, mood swings, horrible weight shifts and changes. There's nothing.
So no recommended pellets.
No. I feel that with the right doctor and the right dosing, you can get to just as good as the pellets. I'm a very start low and go big as you need to, and really titrate it and make it very personal for every person and see how much medicine you need. And when you get there, you stop and you stay. But this is all flooding. You get it all at once. And then little by little, it goes away. But it can be pretty dramatic for a lot of people, and don't advise it.
Good to know. So what about, do we have any side effects with HRT? So now with pellets, we know that it can go a little bit crazy, but should we be scared of the side effects, even though we know that it's going to improve our quality of life? What are those common side effects?
There can definitely, with anything, even with Tylenol, there can be side effects, right?
Yeah.
With anything, there can be. With hormone replacement, there can be, like we said, blood clots. So that is a major risk, but it's a very low risk, especially if you're starting low. And then that is also one of the reasons to have topical estrogen versus the pill. There are lots of studies that are looking at the safety and efficacy of these medications, and they realize that the people who take the pills with oral estrogen have a higher risk of having a blood clot. So that risk is much lower, almost very low, when you're using the patches or the gels. So that is obviously the big one. Bloating, headaches, nausea, mood changes. Everyone reacts very differently. And that's why my recommendation is you go low and then you slow. And certain hormones may not feel well to certain patients. And so in pharmaceuticals, there's probably 6 different types of estrogens. There's probably 4 different types of progesterone. So really working with everyone and feeling which one works and which one doesn't is very important.
So now I know that you are always checking the symptoms of your patient until you finally get the right dose.
Right.
So what is the period of that? Because it's not like I go to your office and say, Dr. Tully, I feel terrible. Let's just do something about it. You give me the dose and then I just go on my way after a month. What is the period that we should be working with a physician like you who is menopause informed?
So again, it depends on the provider and their availability. In practices I've known of, the patient gets the script and they say, I'll see you next year when you come back for your annual. And I think that's not great follow-up at all. Maybe for me, it's too much where I check in with them in 2 weeks, like, how are you doing? I text them. After a month, I have them come back and check in. We do a weight check. We see how it's working. But usually around the 3-month mark. If it's going to work, it's usually around that 3 to 4 month mark where you start to see changes.
Okay.
Nuki, I can tell you, after 4 years of really like delving in and this being my everyday, I finally decided I can't live like this anymore, and I started my own hormone replacement. I was living with crippling back pain for about 2 years. Like coming out of bed, I was like an 82-year-old woman. I couldn't get out of bed. Wow. I put the patch on and took my progesterone pill, and the next day
It was gone.
It was gone.
No way.
My hand pain was gone. It was remarkable. I have back concerns.
So you can see results literally within a week, let's say, because that was extreme.
It was extreme. It was a day. So some people will respond very quickly. Others, it may take quite some time. But there's nothing that I did different that day.
So you just started hormone replacement therapy just now. You are?
I'm 49.
49.
49.
You look amazing, bestie, by the way. So you just now started your...
Yeah, about 3-4 months ago. Yeah.
It's one of the questions I have here. When do we start? Like as soon as you have the symptoms, should I start?
You can.
Okay. There's some other stuff that I should do before asking for the hormonal replacement therapy to ease the symptoms?
There are several different medications that for the 20 years we were trying to bridge people from not losing their mind of symptoms. It really depended on what people's symptoms were. Definitely medications like SSRIs, like Lexapro and Effexor were well studied, and even Prozac in a very low dose was also studied to reduce symptoms of hot flashes. It reduced it by 50% in severity and frequency, so it worked really well. And especially for people who had the mood symptoms, I think it was a really good thing to consider, especially if they were hesitant about starting estrogen. But that is one. There is one medication on the market right now called Veoza, which also helps with hot flashes. It really depends on what the symptoms were, right?
Depending, yeah. In your case, you just had the back pain and then you...
Oh, I wasn't sleeping for years and my hot flashes were crazy. At first it was like, oh my gosh, it's the hot flashes. This is so cool. It's really on fire on the inside. This is really interesting. And then after the 5th one, I was like, okay, that's not fun anymore. The night sweats where I was like drenched in sweat and I was tired of changing the sheets every night, and I just eventually started moving over. I was like, okay, this is too much now. So it came to that breaking point of this is too much and it's not. But I'm one of those people that don't do a lot and don't take medicine and don't complain. So it took me like
because it was only those 2 symptoms that you had, right? So you could have...
There were a couple. Like I haven't had a hot flash in 4 months. It's pretty dramatic.
So there is no way that you take the chance. You can just go check with a doctor like you to just check your symptoms and just have a quality of life. There is no reason why you shouldn't. So what about the patients who are experiencing cancer?
Good question. Women who have cancer, depends on their type of cancer, especially if we're talking breast cancer.
Yes.
Then estrogen therapy is usually not advised, or progesterone therapy is not advised if they had estrogen or progesterone receptor sensitive tumors. Vaginal estrogens, there's some really new studies that are looking at the safety and the fact that the vaginal estrogen, such little is absorbed systemically that they can use vaginal estrogen, because the problem with after breast cancer, oftentimes they take medication that can decrease their estrogen levels so very much that it becomes very dry, very painful to have sex, and just recurrent urinary tract infections, recurrent infections that way. And so vaginal estrogen now has been cleared by many oncologists. That is a decision that has to really be a case by case and discussed with your oncologist and your gynecologist or your menopause provider to see the safety of it.
Yeah, because if you have a patient with cancer, but she is suffering with hot flashes, with heart palpitations, with anxiety, depression, so what do we do? Maybe we do first the other set of medications that you just mentioned before, just to see if you improve, and then the last resort would be try the vaginal estrogen.
But that, again, would only help for the vaginal symptoms. That
the vaginal. So the libido, painful intercourse, those symptoms?
Exactly. Okay. But there's lots of options still. And so I think having that open dialogue and communication with your doctor is really important. And just a lot of women live with their symptoms and don't ask for help, and are embarrassed to talk about these issues, especially after a treatment like cancer, and think there's nothing you can do. And there's still so many ways to be made feel comfortable after something so terrible.
Okay. Will HRT affect my risk of osteoporosis, heart disease, or breast cancer?
For osteoporosis, yes, it significantly decreases your risk of osteoporosis. Cancer, what I had mentioned before, as far as breast cancer, after 10 years and after 60 years of age, and if taken many years after the start of menopause, there is a slight increase in breast cancer risk. That risk is low, but it's positive, and so it's one of those things you would have to take into account and really talk about with your physician about your personal risk. So heart disease, again, that same answer of that 60 is that cutoff, where below that, most women who don't have a baseline cardiovascular risk will still have very safe window to be using hormone replacement. Before I start any of my patients on hormone replacement, and again, because I do all of it, I do a very significant assessment on a patient, cardiovascular health, check their cholesterol, check for diabetes. I check to also see, as far as like a baseline EKG, any symptoms of cardiovascular disease. And sometimes if they do, especially if they're having the racy hearts, I have them see a cardiologist for a full workup before I start them on hormone replacement, just to be sure that this isn't already, there's something there and I'm going to mask it. But what we do see often with menopause is that cholesterol levels go up, and we know that increases your risk of atherosclerosis and heart disease. So by starting estrogen, that usually will lower your cholesterol. So it actually is a nice little thing to see flip down after it's been climbing for years with my patients.
Yeah, especially because 50% of women get osteoporosis later in life. So that is a good advice.
And what's really dramatic is that 50% of the bone loss happens in the first 5 years around menopause.
Okay.
So the time is now to do that strength training you tell everyone to do all the time.
Yeah.
And certainly to consider the estrogen, especially if they have a family history of osteoporosis or if they're not very active.
So how do you know that you have osteoporosis?
Usually no pain. Osteoporosis is usually painless unless you have a fracture. But osteoporosis, you get a DEXA scan, a bone densitometry scan, and it's a very painless exam. You just lie on the table and they do some measurements, and it looks at the bone density. There's some more fancier tests that are starting to become available but are very expensive and really only done for people who already have irregular bone. For now, again, I think it's going to be much more available later on.
That is like in the routine checkup?
It's not so routine. It's usually advised at the age of 65.
Okay.
Or 10 years after menopause, but usually 65 is the guidelines the U.S. Preventive Task Force suggests after 65. But there are people who are at risk. There are people who have had a history of smoking. There are people who may have sick or other malabsorptive disorders, like inflammatory bowel diseases, and people who have digestive issues. There are also people who have history of eating disorders. And if there's a family history, that would also also be a risk, or medications, and even things like thyroid disease can sometimes be a risk factor for osteoporosis. So there's several risk factors, and again, one of those things to ask your provider, ask your doctor about, am I at risk?
Yeah.
When should I get it? And a lot of them will just say 65. Early menopause is a risk factor. So I will usually get a baseline right after menopause, and if it's fine, I'll check them again in 5 years, just to be sure.
So I've been reading about GLP-1s and Ozempic, and
it's a whole other topic.
And that is another episode that we should talk about.
Yes.
I have read that there is bone loss because you're taking GLP-1s, Ozempic, not taking care of the other part, which is that lifestyle changes that, of course, we need to talk about that. The things that you can do, right? Like
100%. So with every pound, essentially, every bit of weight that is lost in the GLP-1s, especially with menopause and all the shifts that are happening in menopause, half the weight is fat and the other half is muscle. And if you don't have muscle to support those bones, you're going to become weak and you're going to be at risk of fracture.
Exactly, because, there's sarcopenia, which is muscle loss due to aging. After the age of 35, we start losing muscle mass. We need to eat an adequate amount of protein. We need to do strength training. And what I see now is that a lot of people are going to ask for the GLP-1s, Ozempic. It's very tempting because you lose weight really fast, especially if you've been struggling. So, of course, it's tempting, and I totally understand that. But not doing the right. So if they're losing bone density, you cannot build bone density back, or can you? There is something that we can do.
You can, and that strength training is one of those things. I have had patients that have done really amazing jobs when they've had osteopenia, and they've either
So it's never too late.
It's never too late, in that we have great medication that when it goes past a certain point, we sometimes need to use, because the fracture risk becomes so high that complications definitely happen if we don't take that into account. But working with someone like you that can keep them strong and not become osteopenic are very important. And again, this time in this perimenopause phase and immediately after menopause, throughout menopause, it is so important to continue that weight-bearing exercise. It is so important to continue the protein, not only again for the weight loss, but again for bone health, for sure.
Yeah, because we have heard about all these benefits that HRT has, but you have to do your part. It's not that you're going to start getting the patches and suddenly you're going to lose the weight. You are going to build muscle, right? So we need to do the part of the lifestyle regardless.
Right. So sad fact is that hormone replacement is weight neutral. So it's not, so people think, oh my gosh, I'm in menopause, I'm gaining all this weight, I'm gonna start hormone replacement, I'm gonna lose it all. It doesn't happen. What's done is done.
Did you hear that?
Yeah.
I need you to repeat that again, because that is, so it is very easy just to blame other factors, right? Like before it was, I'm pregnant, and then it's all this baby weight is here. And then we blame the kids because we're too busy. And then now we are blaming the hormones. So that's why I keep gaining weight. So I think we have to take responsibility and to work on our habits and lifestyle. HRT is another help. Same with Ozempic and GLP-1. They're a help, but you have to do the rest of the things.
Exactly right. And again, like with the GLP-1s and the others coming to market and in the markets, I think the one thing is that maintenance phase that happens and learning how to live with it, and really, again, doing all that hard work and learning how to be healthy. And there is a thought of diet, and can diet contribute to menopause symptoms as far as like hot flashes and night sweats? And we do know that sometimes diet can be involved. Exercise doesn't help with hot flashes, unfortunately. It helps you sleep better and certainly helps your heart. So there are some,
for me, it has decreased the stress. 100%. And then I have noticed easing my symptoms with exercise just because I'm less stressed.
Yes. I always joke that anytime people come in, I was like, I wish I could just write a prescription for a vacation on all my patients and everything would get better. Because stress reduction, cortisol reduction, it makes all the difference in the world, from, again, your glucose levels and how you sleep and everything, and weight for sure. We know that menopause and insomnias and vasomotor symptoms, the hot flashes and night sweats, are directly related to weight gain. So we want women to sleep well, we want them to feel well, and by doing that, they will also avoid weight gain.
Exactly. So caloric deficit very difficult in perimenopause due to insulin sensitivity because estrogen is declining. So important to understand and learn about your portions. You guys are not eating enough protein. You guys are not eating enough fiber.
I completely agree.
And HRT won't help you with that.
No.
But it will help you to feel happier, with more energy, right? Like sleeping better so you can meal prep your protein and your fiber, right? And you can show up to the gym.
Yes. And again, HRT can definitely help with symptoms, but all of that, everything else I think is so important. And not everyone needs HRT to feel well and to be well and to lose weight and to sleep better. It can help for some. So I don't want to be here and say everyone needs to be on estrogen, because I really don't truly feel that. But it can help a lot of people for a short period of time. But it is one of those things to be open to. There's no reason to grit and bear it, but the exercise and all of that will make you feel better. I have not had one patient say, I feel terrible after starting to work out. Everyone comes back energized and happy and smiling, and their mood's better and their sleep's better.
Yeah. So we start with the lifestyle changes. We look for a physician like you who is menopause informed, and then we take decisions just based on that, right?
Yeah.
Good. So does insurance typically cover HRT, or will I need to pay out of pocket?
Great question. Yes, insurance usually pays for hormone replacement medications, specifically estrogen and progesterone. We didn't talk about the bioidenticals. We didn't talk about compounding pharmacies. The Menopause Society and myself don't recommend compounded pharmaceuticals for these reasons. We are concerned about the safety, who's compounding them, where they're coming from, the actual dosing in them, how people are absorbing them. So there are a lot of issues with the compounding versus the ones you can buy in the pharmacy. So I write prescriptions for ones you can buy in the pharmacy, those companies that have been through rigorous years of testing before they can sell you something. I do that, sorry for all the compounding people. But testosterone. We didn't talk about testosterone, lovely testosterone, which is a huge help. We talked about that. Low libido and pain and all that great stuff. Testosterone can be very helpful in menopause, and I write for it often for the right patients if needed.
I understand testosterone is only approved
for men. So it's not covered for women. And that is a concern because it's not covered. The good news is we use such little amounts of it that it is reasonable in price. So the tubes that you would need for maybe 3 months is somewhere like $40. It's 3 months worth, it's still $40. Why isn't it covered better?
So
the HEA supplements are not covered, which are vaginal supplements that we could use for improvement in sex drive and vaginal health as well. That also we didn't really talk about as well, but that is not covered typically with insurances either.
Wow. So we have to save money just to pay for this treatment?
Oftentimes, yes.
Wow.
Yeah.
So unfair, guys. Hopefully these conversations and doctors like you who are preparing professionally to get more informed about this transition is going to open also new doors for us and future generations, so we don't have to pay out of pocket for these treatments that we deserve. I bet that if men were going through these symptoms, we would have had already options for us in vending machines.
Oh, for sure. I
so
completely
easy,
agree.
right?
Yes.
Congratulations on being a woman. But we're gonna get there. I'm very hopeful that we're gonna get there. So I just wanted to take this opportunity to thank Dr. Nicole Tully again for giving us her time. And I have a surprise for you. If you live in New York or New Jersey, she is open to give you a free consultation. You just have to go to her website, www.tullymd.com, and you can book a free consultation. I'm going to put it in the notes so you can talk to this amazing doctor who is opening the doors for us to feel better and happier in the future.
Thank you, Dookie.
Do you have anything you want to share with our audience just to close this episode?
I think everything we talked about, asking questions, listening to your bodies, I think it's so important to ask for help and know that help is available. Finding the right person who's going to listen, being great about exercising as best you can. We're all busy, but even if you can do a little bit, you're going to feel better. Getting enough sleep, eating well, which she'll help you with, Dookie is the expert. I will defer. And just being well and knowing when to get help is really important.
Thank you so much.
And talking to your friends about it, because everyone needs to get involved and know how everyone else is feeling.
Yes, I think we all have that WhatsApp group just talking about our symptoms and perimenopause. Now it's really funny. We just laugh about it. But it's important to understand that you don't want to do it alone. Exactly. You have a team that is supporting you. So we have doctors, menopause informed like Dr. Tully. You have BFF who is going to help you with the other components. So don't try to do everything alone. You can read all you want. We have many books that we always recommend. But the main thing is just ask for help. You don't have to suffer in silence. And yeah, let's just enjoy this transition.
Absolutely. We have to, because there's a lot more to come. We're going to be in this phase forever.
Exactly.
So we have to make the most of it and just learn to feel amazing.
Let's make perimenopause and menopause the best era of our life. So thank you so much for listening. Please don't forget to subscribe, check the notes, because we always have some freebies for you to start your journey. Thank you, and see you in the next episode.